I tell them this is one of the best professions they'll ever be in. And I agree. And I think it is. Like I said, it will bring you so many rewards. I said, you're going to have your hiccups. You're going to have your problems. But I said, and not only that, you will meet so many nurses and friends, your peers, get your team, find out who your buddy is. Those are the things. You'll find that one person that you can share what's happening to you and what they're having experience. And that's your debriefing. That's your resilience, all of those things. So find that person. This will be the greatest profession you can ever be in. And it will be the most rewarding profession. But the point is you also have to find that niche where you really want to be.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks as always for downloading this episode, and thanks for listening to the podcast. Don't forget to share this podcast with your friends, your coworkers, your peers, people you like, people you don't like. Share it with everybody. One way you can help the show out is to leave a rating and review on Apple iTunes. If you haven't done so already, please do that. That's a great way to help new people find this show. My podcast is going up in rankings in the medical category of Apple Podcasts. We're like in the top 100 right now, and that's because of your recommendations and your sharing this podcast. So keep that up. Good job. Anyways, for this week's episode, I have an interview with an amazing nurse I've been trying to get on the podcast for a while. Not only is she an emergency nurse, she's a longtime educator, a forensic nurse, and nurse advocate. You are going to love this episode with my friend, Mary.
My name is Mary Leblond, and I live in San Antonio, Texas. I've been a registered nurse for many, many years. I've been in healthcare for lots longer than I was a registered nurse. So that kind of gives you a little bit of a clue about how long I've been around, some 59 years maybe in healthcare. So a long time. I started as, I went to school into a diploma program. I graduated from there, realized that I needed to have more education, and went back and went to my bachelor's program. And then 10 years after my diploma, and then immediately went kind of from there right into my master's program, did my master's, and then came back a summer and did some postgraduate work. And then life, sort of happened, and we do what we do. And I've been an emergency nurse for 46 years, I think. Always working in the emergency department at some point. Even when I taught nursing for a number of years, and then I would still work my weekends and that type of thing in the emergency department. So it's been, and then of course, my father was an educator, and he always said, this cracked me up because he said, "You're going to want that bachelor's." And I said, "No, Dad, I want to be a diploma nurse," because I work with all these diploma nurses that I thought were fantastic. And he said, "Someday you will." So when I got my bachelor's, I said, "You were right." Then I went back, got my master's, and I said, "I guess you were more right." And since his last name was Wright, that worked out okay.
There you go. I remember getting so I started as an ADN as well. And I remember thinking to myself that I didn't need my BSN. I was like, I don't need it. And then I realized quickly that I was going to need it. And then did the same thing you did, went from my bachelor's right to my master's. And now, I'm kind of kicking around the idea of going back for a doctorate, which, somebody slap me when you see me and tell me not to, or two, I don't know, one or the other.
Well, since I have 23 hours and a thesis to do to get my doctorate, I keep saying, well, but then because life came along and things changed in my life, I had to make some other decisions, and it's not going to happen, but I don't regret the education I got, not at all. I think it was very beneficial to me. And so I'm happy I did what I did in that regards. But
now, what did you do before you were a nurse? You said you were in healthcare before becoming a nurse.
Oh, well, I started out, and I don't know if you even know what Distributive Education Clubs of America are or were.
Oh, yeah.
Yeah, it's like DECA. So when I was I knew from, of course, back in the 50s and 60s, you had two choices, or three. You could be a housewife, you could be a nurse, or you could be a teacher. Those were your options. And I always wanted to be a nurse. So when I was in high school, I signed up with the DECA program and then worked in the hospital, very small community hospital, because we lived in very small towns. And I started that's what I mean in healthcare. As far as healthcare, I started there. And then I worked after going to nursing school and getting out of nursing, and I worked in a nursing home, going to school. I did a lot of that kind of stuff. So I didn't, immediately get my RN. I had some interruptions. Went south to Panama. Went to some other places. So my husband was in the military, and I went and joined him in different places. So that type of thing. So it kept me moving for a while before I could go back and complete my RN.
Yeah.
And then I always worked wherever I was. I worked in a hospital as an aide, or in a nursing home. And sometimes I worked as an aide in the hospital and then would go to a nursing home shift at night. So, I mean, I've always done kind of like double duty, it seems like, working.
Now you work a couple jobs now. You're not slowing down at all. You work I think you have at least a few jobs, don't you?
Well, I'm assigned to the emergency department, so that's my primary assignment. And I'm in a metropolitan city in San Antonio now, hospital. And then I'm also a sexual assault nurse examiner. So that means if they get a case, then I'll leave to go do that case. And then I also teach for a emergency medical group. I go to other places and teach EMPC and TNCC for them. And for a long period, in fact, I worked with a physician group as their educator and resource person. And I would go to their smaller facilities and do education and stuff like that. Haven't done that in in several years, but I still keep in contact with the director of that physician group and that type of thing. So yeah, you're right. I think I do have a lot of hats.
That's all right. It keeps you busy.
Yes.
And then very involved in ENA, being very involved in ENA at the state level. And then do you do any national committee work as well?
I was National Government Affairs Chair for several times. Very involved in national government affairs committees and that type of thing. I'm not on any national committees now. I'm trying to slow down, Kevin. I'm trying to slow down.
I understand.
Anyway. But anyway, and then of course I was involved in Texas. I'm still involved in a lot of the stuff at Texas. I was Texas state president. And then I was chair of government affairs for Texas for many, many years. And then been on different chairs of committees on the state. And then at the local level, president. And then, of course, different committees and different positions in the local chapter, as well as I'm still the nursing practice government affairs chair for San Antonio, ENA.
Nice.
Yeah,
nice.
Keep busy. I'm on Department of Health and Human Services task force for workplace violence. And so I review grants, workplace violence grants for them, and then participate in some of their activities that they have as well. So it keeps me busy.
I guess so.
Yeah.
Holy cow. Very cool. Well, boy, you've done a lot of different things over the years.
Yes, I have. Nursing, I tell everybody, nursing is a career that will open the doors to more things than you've ever thought you could. When you look at what you can be a school nurse, an industrial nurse, you can be a forensic nurse, you can be, you can do anything, education. I mean, you can teach, there's just so many opportunities. You can be a pediatric nurse, an ICU nurse, you can be anything you want in nursing is probably out there and open to you. And if not, it's like legislation. You can always be a consult for your legislators. Send them a letter. Tell them that you're interested in helping them as far as like with bills that have related to healthcare. And I think that opens a lot of doors to different people and different things that you can do as well. So that's been it's just been a terrific opportunity. There's no doubt about it. And I think ENA and nursing has brought that to me by far. And then the number of people, Kevin, how many, can you walk into any state and not know somebody that is part of ENA? No, you can't. I mean, there's always somebody somewhere. When you go to those meetings, it's like seeing your old time family friends for, every year. In fact, sometimes you see those people more than you do your actual family members, it just depends.
That's probably true. I remember when my very first meeting at the Texas state meeting, my very first meeting, I just moved to Texas from New Mexico. And I remember looking around and seeing so many people I'd seen over the years at national. And so, I'd seen Sally Snow, who I knew, Stephen Jewell, who I knew, I knew from presenting at the San Antonio ENA conference, right. Carol, so many more that I was like, holy cow. Like it was, and I walk in and just the welcome that you get from your ENA peers was really, really cool and meant a lot to me because that was my community in New Mexico for a long time. And then I came to Texas, and you never know what, a new group's going to look like. And Texas is so much a bigger entity than the New Mexico State ENA was. I wasn't really sure what to expect, but it was phenomenal. Like I couldn't have asked for a better reception and warmer people.
Well, I would say in Texas, come to a meeting, you'll be voted in as your state president the minute you get there. I mean, that's pretty much how it happens sometimes. So I think we're trying to refine, we're refining everything all the time, but it always, anything can happen.
My very first meeting was, I want to say it was a third quarter meeting, and they were talking about people who were running for office. And someone looked at me and go, "Hey, are you going to run for state office?" And I was like, "I just got here. No, I'm not." Yeah. And the truth was that I had already been voted onto the Houston chapter as a member or as a director. So, and that was because I showed up to the first meeting as well. So, go
to the bathroom.
You go to the bathroom. You come back president.
That's right.
So, anyways,
too much fun.
I got to tell you, it's been amazing for me, and just the amount of people it's given me access to, and the experts it's given me access to. I mean, you look around, and for those of you who don't know, in Texas we have something called the Council of Presidents, and the Council of Presidents is all the past presidents of the ENA, and they try to do some work for the council. And it's a great way to tap into that experience, that past experience of people who've been there, done that. And we have former national presidents in our group. We have former national board members. We have a wealth of people who's current board members. That for a while we had current board members. What a wealth of knowledge to be had there. So because very few problems in the ER are original. Like every other ER has figured out something. So,
yeah, it's amazing the number of people, like I said, that you've been exposed to and still keep in touch with. That's the other part. It's just like I got an email the other morning, like at 3 a.m, somebody showing me all the snow that's happening in Colorado, and like there's this huge blizzard up there, and she said, "Welcome to April," in Colorado. And it's 13 inches of snow blanketing her patio. And you're looking at this going like, this is really awesome. But, you get these text messages, you get these email messages from people who need help. The other day, I got an email or a text message from people at work. And because I had worked on the legislature to make it a felony to assault a healthcare provider, they'd had a big assault. And she said, and the police didn't want to prosecute. And she said, "I had to call you. I know you work really hard. You always advocate for us." So then, they call and they say, "What can you do? Can you do anything? Can you go down and talk to anybody? What can you do? I know you really worked hard on this bill." And I'm going like, yeah, they can't say no. And so then we talked through that. So those are the things that you get out of the blue that you never would have probably gotten had you not made those acquaintances in life or with ENA and the work you've done or whatever. So, and I kind of laughed when she said to the police, "Don't you know who Mary Leblond is? Don't you know who Mary Leblond is?" And they're going like, no.
No, never heard of her, but okay.
Yeah, right. Well, and most of them are like 25, and they probably, this bill's, older than they are. Some of them, so you look at that and go, not quite, but it's been a long time.
Been a long time.
Yeah.
Tell me, let's talk a little bit about patients you've cared for over the years. Tell me about a patient that you cared for that you'll never forget.
The good, bad, and the ugly? Is that the one you want to know?
And any of the above or more than one is fine.
Oh, my goodness. Of course, you always remember, I think, your first child abuse case, because that's so devastatingly unreal in your vocabulary. You think this can't be happening. This couldn't have happened. And yet it did. So I think that you'll never quite forget. I think you'll maybe remember the first patient that died and that you were caring for, or that you were in the ER when they died, whether it be an adult or a child, because I think how you manage that and how you grew, because I know my girlfriend and I know this sounds really morbid, we do death well. And I don't know how and it's not that we do it well. It's just that we feel very comfortable in talking to the family and bringing the family in and having them share that loved one's experience. So I think those are the things that I remember. Do I remember specific faces of people? I do. I remember people holding my hand. I remember people, those are the things that bring out tears really tears, because they're special moments that you wouldn't have had you not been in this profession. And so I think those are the things I remember. Some cases, I mean, there's funny cases. Terry Foster tells the funniest stories about patients. I would love to share a story about a little girl who described anatomy, and and then she looked at me and she said, "You're really old." And I thought to myself, "Thank you." And then she looked at the nurse beside me, who I'm trying to work with. She said, "And she's really young." And I said, "Thank you." I said, "You are a very smart little girl." What am I going to say? You're right.
You're a really smart little girl. I'm getting ready to punch in the face.
But and so those are the memory, the kids, the funny things they say, the things that they ask you. And I think those are the memorable moments, even during the most, like as a sexual assault nurse examiner, the most crisis event probably in their life. And they're so resilient and happy. And you're thinking, what impact is this going to have later on them? And you hope that they can retain this resilience and this joyfulness. So I think those things impacted me. I'm trying to think of something a patient said to me once that I don't think we ever stopped laughing. But and you bring up those stories. I can tell you events. And if you remember back a long time ago, Terry Foster, Jeff Solheim, and I were on a panel where we talked about incidents, funny things, or things that happened in the emergency department. And I brought
love to hear a recording of that. Holy cow!
Yeah, and I was talking about a time when we had a physician who said, back in the day, I said we had A was for the trauma. I mean, we had rooms that were A, B, C. We didn't have numbers. We had A, B, C. And then the gyn rooms were, and the pediatric room, LMNO, And of course, when they got back in the gyn room, they had squatters' rights because they never left. They had to come in, had abdominal pain, and then they had to have their exam, and they had their pelvic exam, and then they had to go for their ultrasound downstairs, and they had to go to their CAT scan, then their OB-GYN came. So they never got out of that room. So every abdominal pain sat in the triage area forever until we got a room open. The abdominal pain had to be open, and that was the craziest thing. So we had a physician who said, I don't need a gyn room. I can do a pelvic exam in any room. And so what he would do is he would scoot the patient to the bottom of the stretcher and then sit on a stool, and he put one foot on one leg of his and one foot on the, laying flat. And then that would be the stirrup, so to speak. And then he would do his pelvic exam real quick. And it worked out amazingly well. And he didn't need the pelvic room to do a pelvic, which everybody thought you had to do at the time. But the funny thing was that was great. He was awesome. But the funny thing is we had a new doctor come to the emergency department, and he got so upset over the fact that we had all these abdominal pains were in the waiting room. I mean, he'd pick up the thing and look, abdominal pain, and they were all waiting to get back in the gyn room. And so we told him that this doctor always did it this way, and we could, and so the charge nurse was going to show him how to do it, right? So and I told the story at National, so this is not a new story, but so what she didn't tell him was that the feet should go on his thighs, rest on his thigh, flat on his thigh as like a stirrup. So the feet were on his shoulders instead of his thigh. And so the whole thing was...
It just looks dirty. Holy cow.
As he went to put the speculum in, she pulled her shoulder. She pulled back. And of course, he was like right in the... And he said that truly is the meaning of sniffing position. And so I told that story at National because it was so funny, because here's somebody trying to show somebody. And so he had to get on the phone and tell his wife, who was a nurse, and oh my gosh, it was, so we never forgot. So we always called, we always gave him a bad time about it, of course, because that's what we do. We had just a little bit, but it was so humorous to think about, what he was doing. And we're just laughing because it was funny, but of course we tried to be very professional and pretend like it was normal, but it wasn't. That was not the position he was supposed to have the patient in, but to do the exam. So needless to say, that went around to the physician who obviously invented the position that he didn't need a gyn room. And it was so funny. It was, but
that's funny.
Yeah. So anyway, that was part of it. So
Poor
we have
guy.
Many humorous events we can talk about, I guess, and I don't think you can recall of them. I'll probably get off here and go, oh, I remember that and that and that now. But,
That's always the case. You always remember it like the worst time. So,
yeah.
Oh, that's a funny story. Holy cow.
Yeah, I told that at the national meeting, and I mean, everybody was laughing. It was like, and Terry Foster, of course, had to jump in and add his 2 bits, and it became quite comical, actually.
The three of you together, I'm sure, were just a riot.
Yeah, it was like
Just a riot. So
but it was fun to do.
I bet. Holy cow.
I mean, those are one of those experiences I didn't expect. They asked me to do it, and I did it. So it worked out really well. But I mean, it was fun. It was fun to do. But
oh yeah, one of the things that has been so great with this podcast is getting a chance to have people share these stories that are just gold. These are the kind of stories that really just kind of make this podcast and really make it something that people want to listen to. So.
Well, edit out some of the bad stuff.
Well, I will. Well, don't worry. We'll edit some of this out.
I would normally use, I would not normally ever use names in that situation where I'm talking about it. But at work, of course, we use names all the time because we all knew who did it. And then it was like, yeah.
That's funny. Yeah, absolutely. Absolutely.
And then we have a physician who always wants a rectal temperature on patients because he said that's the most accurate temperature. And I'm up in triage one night and I can't find anything really wrong with this lady except that she just doesn't look right. And I can't figure out what's going on with her. And he said, get a rectal temperature. I said, in triage? And he said, yes, her temperature. And I said, well, her oral was like 98.9 or 99. I don't remember. And her rectal was 102. He said, yeah, well, we found our problem, haven't we? And I said, yeah, you're right. But so those are the things that you learn over time that, your practice changes. Not that I want to do a rectal temperature on every single person, but it did make a big difference. And if we didn't do it, he did it. He would do his own rectal temperature because he knew the significance of that core temperature versus what we got on the temporal or the oral that wasn't so accurate or whatever. And he found more problems. And I said, now we have all this. And he said, well, now at least we know we have something to work with. We have to go investigate. So he was very smart. So you learn a lot from all the doctors. I mean, can't tell you how many doctors I've worked with, just over the years. You got to figure in the number of 58 years or whatever it's been since I started working in a little tiny rural community hospital to now. I mean, a lot of physicians and a lot of nurses, a lot of great nurses. I've learned so much from nursing too. And it's just a matter of listening and watching what they do. Pick up. I still learn every day. You can learn something every day, I think. There's something somebody will teach you.
What's the last thing that you learned that you were like, oh, wow, I didn't know that? Like where you're like going, like, I should know this and I didn't.
Well, actually, I just finished my forensic lecture that I had to do. We have a webinar. We do 4 for Texas, where we do the webinars, where we do the geriatrics, the forensics, and the jurisprudence and ethics, as well as the human trafficking, because they're all licensing requirements. And so on the forensic one, I was going through my notes and I'm going like, wait a minute. I don't remember that. What did I do? So I had to go back through and research. And so I called work and I said, are we doing this or this now for our protocol? And they said, no, we're doing this. And I said, I think I missed that somewhere. So, I mean, that just happened this week, as I'm looking through my notes going like, I have to change that in my lecture. And I guess I missed it somewhere along the line that I didn't pay attention. I don't know. But we changed, some of the things we were doing and how we were doing it. And I said, I just need to update that. So, and that was calling the work and getting that information from people at work. So I think it's really valuable if you listen, you'll learn stuff. We have a new colposcope that's like a handheld one. I mean, it's like pretty amazing. But I mean, I've not been in service on it yet. To be honest, I need to do that. But it's like the new stuff that you see coming out, the new equipment. And Paul Clark and I were talking one night and I was telling him how we were looking in mouths with different things. And he said, did you ever think you should do an in-service on how to use instruments that aren't intended for what you're using them for? Because he laughed and laughed. And I was telling him that I couldn't see inside this lady's throat. So I just took the top off the speculum and used the speculum. And of course you have to explain very nicely what you're going to do because it sounds really odd when you say I'm going to use. But and I show it to him, I show it to him. But it's so nice because it has a lighted source and it's not like a tongue blade that only pushes the tongue down in one spot, kind of pushes it away that you can see with the lighted resource. You can see up into the, you can see all across the back of the mouth and you can see up in the top of the palate and you can see the tonsils really clear. I mean, it's really a great tool, but it sounds really odd when you say you're going to use the speculum in their mouth. They go, what? So, but there's other things you can do with that speculum too, by the way.
There's
You may want to edit that one out. I'm not sure. But
that's good. That's good information. I seen a doc do that once, and I remember thinking to myself, okay, that's just weird, but it works. And there's so many things like that were like, okay, it may not be, the way this was intended to work, but it works. So.
And it works really great, especially if you have strangulation, where you have the petechial hemorrhages, or you have the, the oral insult that went on, and you can't see that well. If you're just opening the mouth and looking, you may not see it that well. And a little pen light, or even our otoscope lights don't look. I mean, you can't see as well, but this one really lights it up and lets you see it, and it helps pull the tongue out of the way and all of those things. So it's a great instrument, but it certainly is not what it was intended for.
Yeah,
but,
absolutely.
In
your years of practice, what are some of the things that you've seen that have been changes over the years, both the good and the bad changes? Maybe we can start with the good first. Things that have changed from the time you started as an emergency nurse and forensic nurse till now, things that you've seen change over the years that you're like, okay, this was a really good change.
Well, I think when you go back to when I started in a hospital, we didn't have paramedics, EMTs, ambulances. They didn't exist. They weren't there. If you had an accident, who came to get you at the hospital, anybody spare to come with me, that was a funeral hearse.
Yeah.
And he would pull up and he'd say, or he'd call and he'd say, I've got an accident out on whatever highway. And then do you have anybody that can come help me? And it literally was scoop and run, because, no equipment in that hearse at all. All you were doing is picking them up and bringing them in to be cared for. So that, I think, if you're talking about that care, how it has evolved from where we were to the fact that we're giving blood in ambulances now. All of that care that's evolved in their history, not to mention what impact it's made on us being the first receivers of those patients that they bring in, has made a dramatic difference. We always talk about the fact we didn't have respirators. We didn't even have those. They didn't exist. We had a little green bird thing that went tweet, 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 and we called it the bird. And that's what we used to help people breathe. But we didn't have respirators. We didn't have ventilators. We didn't have those things. So those would be equipment thing. The other thing I tell people is we didn't really, anybody who came in that was trauma, we cracked their chest. That was just routine, because we didn't know a lot about that. You could do external cardiac compressions. We didn't know how, there was no fast exams. There were none of those things that went on. So you can't see the inside there. So the only way we could see was crack the chest. Did we have successes with those? Probably not, but there are at least not very many. So those type of things, we did. And then the internal paddles that we would shock somebody with, we did that in the ER. So that's a whole lot different than not that we can't still crack chests in the ER. We have, I'm sure some of people have seen people have that done. And we talk about it when we teach TNCC. But the point is to see it in reality, to watch it be done is different.
It is. I remember, I was super excited. I always wanted to see it when I was a brand new tech in the ER. I was always like, oh, I want to see this. This is going to be cool. And then you see it and you're like, that's not really cool. It is cool. I mean, the curious person, the curious mind in me is like, wow, this is kind of fascinating, cool. But the thing is they typically don't survive. Typically don't survive. And I remember I worked with a woman named Katie, and Katie was probably in her mid 60s when I was, first working with her. And she was, she would always be like, I'd be like, ooh, Katie, I want to see him crack a chest. And she's like, they're so messy. They're so messy. They make such a mess. And you're like going, I know, that's cool, right? And they're like, no, Katie always said that she's seen 3 people. I'll never forget. She always said she's seen 3 people survive getting their chest cracked. Right. And I never seen one that survived getting their chest cracked. So I've not had that experience. But she was always like, they rarely survive. And to my knowledge, personal knowledge, I think I've seen it probably half a dozen times. I've never seen anybody survive it.
Yeah. I've seen one I know of that survived, and one that I think we got to OR, but, didn't survive after that. Survived for us to get to OR, those type of. And I'm telling people like flail chest or another thing we used to treat horrendously barbaric, if you think about it. Of course, now people sign up to have this done. But, we used to put towel clamps on those little rig rib fragments, or we put sandbags on the side of their chest. We did, other things that we did that we don't do anymore. But we put these little towel clamps on these rib fragments and then hang them over the top of a trapeze bar on, those old orthopedic beds that had the long metal orthopedic bars that went up and down and across, and they trapeze bars that they pulled themselves up and down with. Yeah. Well, we would hang, that we'd take the towel clamp hook to a rope and then hang it over the top and then put a little weight on the end to hold that fragment away from the chest wall.
That sounds terrible.
I know. It's like the things we did, the barbaric things in a way. When I went to school, the atrium didn't exist. They were called auricles. That's what my textbook said. They were auricles and ventricles. They were not atrium and ventricles. So just a transition in terminology. And how we used to say OD, OS, and OU. We don't use those terms anymore. They have to be, because I don't guess people can't figure out what OU and OS is, so they identify them by the names. How we changed in that documentation has changed dramatically. And not for bad. I think it's all been good from that, but definitely what has changed in with the process, like seatbelts. Do people die from seatbelts? I tell people, yes, people have died from seatbelt wearing one. But the survival rate is so much great because when we used to go out and pick up these patients, they literally were through the windshield. And they would be in the back of the station wagon and they would fly right out that front windshield. And so you think about those things and the lives that have been saved with seatbelts and car seats and all of those things. That has made a dramatic difference in emergency care. Not that we aren't having bad accidents and people are dying from them, but at the same time, the incidence is so much less than what we saw before pre-seatbelts. We used to call a seatbelt the mother's arm that slapped over and held the kid in place. And we all know that's so ineffective. But the point of the matter is that's what we had. We didn't have seatbelts. So those are the things that I think have really made a difference in practice because they don't, it's been great from that perspective. We have all this advancement in safety features and that have saved lives and made our job in the emergency department much easier because it has saved lives. So we get and so that I don't know, those things just always amaze me is how science and medicine has gone together to make our care better, and it is better in so many ways. Insulin, we remember how you used to draw cloudy to clear, clear to cloudy. Remember you had to go through that whole process. You had to learn. So by the time you figured it out, they switched it back. And, it was like, which is the one we're doing this week? But, just those type of things were, when you look at those, the progress and the differences we've made in care, it's pretty amazing. I tell people about decubitus and how we used to paint them with methylate and Maalox, and we paint these decubitus with those and hope we cure them, and did amazingly many times. But at the same time, what we can do now compared to what we did then is ironic. And cervical, remember the old circular electric beds and we used to have the ones where we'd flip them every time and over and back and back and over, and they had to be on that bed forever and ever for 6 weeks or longer, why they had to, some of the stuff it's amazing that we used to do, and people survived. I tell people that, and people survived.
All that, and people survived. Is there anything that you think has gotten over the years in nursing that's gotten not as good, that like you think, we should go back to the way that used to be for, this particular part of nursing?
I think the electronic medical record has destroyed our patient care act. I really do in so many ways. Not for all nurses. I can't say this in general, but when you're treating the computer versus the patient, and I see that because we're documenting. People I have a friend who always said they stand out in the hallway and they ask questions. I used to have a physician who'd stand with a stethoscope out in the hallway and hold it up. And Mom, what do you think what do you think's going on? And he has a cough, and I'm going like, are you going to go in and assess that kid? No, I can do it from here. I'm going like, okay. But so the same thing with computers. We stand in the hallway or the end of the bed and we document all the stuff in the computer, but I don't think we put our hands on the patient, like we used to. The personal touch maybe is, and again, not all nurses, please bear in mind, I'm not condemning all nurses. But that seems to be the focus. You've got to have that in that electronic medical record. It's not what's going on with the patient. It's what's in that electronic medical record. And I think that's where, that's the sad part, the very sad part.
Yeah, we spend a lot of time nursing the chart, don't we?
Yeah, we do. You got to, if we don't have this, and it's like I tell them about the MOT. I laugh when I teach TNCC. I said, you have to have the MOT signed by Jesus, or you can't let him out the door. Because how many times do you have to have your supervisor put your name on it, your name has to go on it, the charge nurse's name has to go on it, and then you have to put your 3-4 ID on it too, just in case they didn't know who you were. So, I mean, it's like, and by the time you get all that done, the patient could be gone. I mean, out of there 5 times. So it's like, I've concentrated so much on some of that stuff.
Now, for those of you who are not in Texas, who have no idea what an MOT is, an MOT is a memorandum of transport, which is a document transfer, which is a document that we have to have filled out anytime we send a patient from one hospital to the next. And it's a Texas thing. There may be other states that do it too. I don't know. But I know prior to me coming to Texas, I never seen an MOT before in my life. And now I sign, 5 a night, Yeah. But it's a transfer document that Texas uses. So,
yeah, it's, there's so many things. I mean, state by state they're different things. So it's hard when you're teaching or lecturing to one group because different states have different practices, different laws that govern their nursing practice. It's like I tell the nurses, I said, you need to know what your nursing practice says and what you can do and can't do. And some of them say, oh, can I do that? Can I do that? And I said, I don't know, look it up in your nursing practice. I know they can do it because that's why I'm teaching it. But but at the same time, a lot of them, I can't do that. They wouldn't let me. And I said, policies and procedures govern you too. But we have a lot of over-regulation, I think. That if you're asking me about things I think that aren't as good, I think that's part of it. I can tell you stories about patients that were, well, I love to tell the story about the young kid who came in who walked into the emergency department and said that he was walking home from choir practice. No lie, this is what he said. He's 16 years old, and his friends, and he said he felt something hit him in the chest. And he said, oh my gosh, that hurts. And finally his friends looked over and they said, you're bleeding. And they brought him in a car. They walked into the ER. We took him into the trauma room, took an x-ray, had a bullet in his heart.
Holy cow. Didn't realize he had shot.
No, he didn't. No. And the bullet was tamponading the bleed. So I'm thank goodness it was there. From that perspective, shouldn't have been there in the first place. But, and so back in the day, we used to have to call and get Medcom transfer, blah, blah, all that kind of stuff. Well, there was an ambulance that pulled up outside. We put him in that ambulance. They took him over to the University Hospital. He was in surgery in 20 minutes and survived. Maybe 40 minutes. I don't know. I could have times wrong a little bit, but not much. I mean, it was very, very quick. Well, now we got to get the approval, got to do through this. And I'm not saying that's wrong in so many instances, but at the same time, we certainly did things for the patient at that moment in time. That was what saved that kid's life. How long could he have gone on like that? We don't know. But it was pretty impressive. And the fact that the EMT guy or the paramedics that were outside, they just brought a patient in and they said, load him up, we'll take him. That's pretty, it was like a camaraderie between us. We got to do this. We're going to do it. And that's it. It's kind of like ask for forgiveness later. Same thing, sometimes you want to get those patients in and out so quickly that we're hindered by our laws and regulation. And that's frustrating, I think, as an old-time nurse, because we used to do things so different. We had a nurse who we thought, an allergic reaction, quote unquote, in our emergency department. And we put her in the bed and her blood pressure was off the top of the charts. It was really high. And we were going like, what the heck? And she said, I don't feel good. And we're going like, okay, what's going on? And we thought she needs to get up to ICU. So we called one of our cardiologists. She said, just send him up to ICU. I'll see him there in a minute. And then we called the charge nurse up in ICU, who we work very closely most of the time with these people. Now it's, I think, more distant relationships. Not all, but in some cases. And so we called her and she came down, took her upstairs, and she survived, but she ended up going to surgery and having to have 2/3 of her lung removed because she had a huge empyema in there that they had to evacuate, and ended up removing a good section of her lung. But it had nothing to do with an allergic reaction. But here was a situation where that patient went immediately from the ER to ICU to practically OR, in a matter of a very short amount of time, which nowadays I think we'd be hindered with, well, we can't take her to ICU. We can't just roll her up there. We've got to go through all this process of getting acceptance and physicians and whatever. So I think that's helped up to some extent again, but, and good and bad, you get good and bad with everything, there's good and bad with everything. It's a good thing that we can't do some of it, but it's a bad thing in a way for patients from that perspective. But she's alive. I mean, she's fine today. I mean, you know.
What
And
advice?
still work. Still work.
I'm sorry.
No,
And still
and
working?
no, actually, she retired a few years ago, but she would work. She worked for a very long time after that. Very long time afterwards.
Yeah. What advice do you give brand new nurses coming into the emergency department?
I tell them this is one of the best professions they'll ever be in. And I agree. And I think it is. Like I said, it will bring you so many rewards. I said, you're going to have your hiccups. You're going to have your problems. But I said, and not only that, you will meet so many nurses and friends, your peers, get your team, find out who your buddy is. Those are the things. You'll find that one person that you can share what's happening to you and what they're having experience. And that's your debriefing, that's your resilience, all of those things. So find that person. It's not necessarily your spouse, because I always tell everybody I was married to an ICU nurse, and I come home and he didn't get what I went through. And I'd say, how was your one patient today? But you got to remember, this was several years back. That's not what happened in ICU now. ICU nurses are getting hit hard. I mean, they're having the 3 or 4
100%.
patients. Yeah, they are definitely getting hit hard. So, but I'm saying back in the time when you got to remember that my husband's been gone for 25 years. So, we're looking at a long time back there. We're talking. But so you look at those things and you think, so find that this will be the greatest profession you can ever be in, and it will be the most rewarding profession from a standpoint of the patients. But the point that you also have to find that niche where you really want to be, because some of us aren't made out to be pediatric nurses. Some of us aren't made out to be ICU nurses, but you can have that. Maybe you're a school nurse. I mean, and that's a great profession. Sexual assault nurse. Everybody wants to be a forensic or a sexual assault nurse. And I'm not sure. I mean, I have more new grads come up to me, and I've always been interested. This is what I want to do. How long? I mean, can I start? When can I start? Those type of things. And I think it's hard as new nurses to say you have to put in the time before you get the dime. That's kind of how I look at it. But that's not what it is anymore. I mean, they go right into like almost all the nurses I'm teaching in this health group I'm with are new grads that are going to be ER nurses. And that wouldn't have ever happened. I mean, I used to say somebody'd have to die in the ER before you could get a position in the ER, because they stayed there that long. They were old nurses in the ER.
When I first started in the ER, it was the tenure there was incredible. And now every ER I know, there's new grads in every ER, and ER nurse new grads are getting put out in the ER faster than ever before.
Right. And so I tell them, and the other thing I tell them is don't ever stop learning, because you don't know everything just coming out of school, and you know a lot. In fact, I tell them when I teach, I hope you can learn as much from me as I know I'm going to learn from you, because they come out with the fresh news, fresh ideas, fresh insights that are very, very beneficial to an old nurse. And then you get, or at seasoned nurse, I'm supposed to say, I guess. But anyway, and then but never stop pursuing learning, because every day you will learn something new from your patients, from your physicians, from your peers. And I said, that's the exciting part about this. It's never stagnant. We just are constantly in a change mode, which is kind of fun if you like change. That's why we're ER nurses, right? We don't want to hold on to patients for hours and hours. And and they find that very difficult to deal with. The fact that we're holding patients, that we can't send patients. I think that's hard. So I said, you just have to figure out how you're going to maintain your resilience, keep learning, find somebody, all of those things. I think those are the most important messages.
Absolutely. Absolutely. One of the last questions I always ask my guests is a question called 3 things. And if you had to give an ER nurse 3 things to remember, what would 3 things an ER nurse should always remember? And what are 3 things they can just forget? Don't do that. Forget it. Don't.
Well, I think I kind of covered a lot about what I think remember, and that's keep learning. Yep. Because I think you will always learn, and watch other people, because you'll learn techniques and skills that you didn't know. I mean, that's amazing to me. I'll be watching. I remember the first time I watched somebody tape down a catheter, because now they have catheter guards, but at the time, and I thought, that is so cool how you did that,
What a great idea.
Yeah, right. What a great idea. Yeah, those little things like that. So I'm always going like, that's always important. So keep watching, listening, learning. I think those are the important things. As far as things to forget, guilt. I think we carry a lot of like personal guilt home with us. Oh, if I would have, should have, could have, those, those negative things that we do to ourselves that we want to say, get over that. You can't take that home with you. And that I said, and I'm probably I'm the one that does that. So I'm the one that gives you advice and says, don't do that. Because I think that's where we get in trouble, that guilt. We always feel like maybe we should have done something. And then kindness. Always remember, I think always remember to be kind to others. And I think how you treat others, they'll treat you, those type of things for good things. And move on and keep moving forward. You did what you could. You did the best job you could, as long as you know that you made the decision. And that's the other thing, decision making, because I think we always second guess ourselves later. And I think you make the best decision in that moment in time with the information you have. And you have to really say that's where you have, and then move on. Because if you don't, you'll be weighed down by this guilt or this horrible thing that happened. And it's life. Life is going to happen regardless of whether we want it to or not. And are there situations and reasons behind a life we'll never understand probably, but move forward, keep moving forward.
Ain't that the truth?
That's it, I think. So, and I think, like I said, I think becoming a forensic nurse was a good decision that I made many years ago. And I think those things are important. I mean, whatever you do to build your career, I think makes you, I think it makes everyone a better nurse. The more things you can add, the more things you can learn, the better nurse you'll be.
Now, what certifications and such do you have?
Okay. MSN.
Okay.
RN. CEN. And then CA-SANE. CP-SANE. That's for, I'm a pretty pediatric and adult certified SANE. And then FAEN. So
can't forget that. Can't forget that FAEN.
That was a highlight of my career. That, getting the Gail Lenehan Advocacy Award, all of those things were really true highlights.
When did you become a fellow?
Oh my goodness. Oh my. I don't know if it was 2014 or 20. I don't know the exact date. 2014, 2015. I think it was 14. I don't know. Isn't that silly? I don't remember dates, but I do remember the events. And boy, I'll tell you, that was, well, you just got it, right?
Yeah.
It's like, it's the pinnacle of your career.
How do you describe it? Because one of the things is someone's asked me, I've been asked a couple of times, how do I describe the FAEN? And the kind of the canned responses, it's for people who've had lasting contributions to the profession. But how do you describe it? I'm just curious for myself, because people always ask me, and I'm like, it's kind of hard. I'm like, how do I explain this? And you're right. It's the biggest honor to date that I've had is becoming a fellow. And I absolutely was like, I'm not qualified to be in this group of people.
Yeah. I mean, number one, I mean, like I said, it's the pinnacle of your profession. I mean, It is. There's no other description for it. That no matter, I mean, when you hear what some of these fellows have done, you're like humbled. You're humbled to think that you belong to that group of those people who have, have made that contribution, have done what they've done, and you're just like, oh my gosh, But you're so honored to be recognized as that fellow, because you want to think in my nursing career, I want to think that I've contributed to nursing, to emergency nursing, obviously, but to nursing in general, whether it's through the teaching, whether it's through practice, mentoring, advocating. When they asked us to put up that thing and for our fellows, they said, well, what area do you find that you are the strongest in? And I'm going like, I can't pick one. Because it's accumulation of who you are. And that fellow is accumulation of who you are and what you have accomplished and what you wanted when you said, I want to be a nurse. That was it.
Well, Mary, I've really enjoyed this a lot, and I really appreciate you taking the time to do this with me. And I'm so thrilled to get to know you, thrilled to be able to call you a friend, and honored to have the chance to know you.
Well, thanks, Kevin. I feel the same way. I just have been so blessed with nursing and special people in my life, and thank you for being one of those people. I appreciate that.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.